Welcome to the American Shoulder and Elbow Surgeons podcast. I'm your host, Ruth Delaney, a shoulder surgeon in Dublin, Ireland. For this episode, I've been invited to be a guest host, and I will try to live up to the high standards set by the regular hosts, Rachel Frank and Peter Chalmers. Before we get started, I should mention that the views expressed in today's podcast do not necessarily reflect the views of the ASES, University College Dublin, or of the institutions of any of our guests. Today, we have an episode focused on one of my favorite topics, shoulder instability. And we've been asked specifically to discuss two important and somewhat controversial shoulder instability procedures, the Latarjet procedure and the Remplissage procedure. For this podcast, we've invited two world-class experts on shoulder instability, both of whom have published widely on these procedures and who may come from slightly different camps when it comes to soft tissue versus bony reconstruction for instability. We are joined by Dr. Patrick Denard, a shoulder and elbow surgeon out of the Oregon Shoulder Institute in Oregon. Patrick, welcome to the podcast.
Thanks a lot, Ruth, for having me. It's a pleasure to be on this podcast, especially with one of my mentors, Gilles.
And we are also joined by a surgeon who many of us have come to think of as the father of the modern Latarjet procedure, Dr. Gilles Walch from Lyon, France. Bonjour, Gilles, and welcome to the podcast.
Thank you so much, Ruth. It's a pleasure to be here with you and with Patrick. Thank you for inviting me here.
So I'd like to start with you, Gilles. I remember you telling me as a fellow the story of how the Latarjet procedure originally came to be. And some of our younger listeners might not know how Michel Latarjet happened to perform his first Latarjet procedure in the 1950s in Lyon. Can you tell us that story?
Yes, Michel Latarjet was a general surgeon in Lyon, and he attended the operating room with Professor Triat. Professor Triat was a true orthopedic surgeon, one of the first in France, actually. And Latarjet just came to visit him and to see what he was doing, because at that time, the general surgeon in France in the 50s were doing also orthopedic surgery. So he saw Professor Triat doing the classic Triat procedure, which is a kind of osteotomy of the coracoid at the basis, and lowering, medializing the coracoid in order to put it lower and to prevent the dislocation. It's the different procedure from the Latarjet. So Latarjet said, "Oh, it's a nice procedure. I'm going to do that." So Latarjet went in his operating room and tried to do the Latarjet, but I tried to do the Triat procedure. But during the surgery, he broke completely the coracoid. Instead of doing only osteoclasia, is that correct? Osteoclasia?
Yeah, osteoclasis, yes. Yeah.
Osteoclasia. He just broke completely the coracoid and discovered that he did not know what to do. So he just said, "Give me a screw," and he just put the coracoid in front of the glenoid through the subscapularis with a screw. So it was like this that the Latarjet procedure started.
That's pretty amazing. It sort of started by accident.
By accident, exactly.
Yeah. And Patrick, do you think it's probably fair to say that the Latarjet procedure is less favored by North American surgeons than by Europeans in general? I mean, why do you think that might be, or do you even agree with that statement?
Well, I think you're absolutely right. I think a lot of it over time, right? You know, if you're in Europe, you've been exposed to Latarjet more. If you've been in North America in your training, the upbringing has been Bankart transitioning to arthroscopic Bankart and now Remplissage. So, like a lot of things that follow patterns of our mentors, right?
Yeah, for sure. And I think we maybe don't spend as much time, in our training in North America doing open instability surgery of any kind. Maybe we've become more comfortable with arthroscopic procedures, and maybe that's part of it. And then I think it's the population too. I don't know how you guys feel about the population. Here in Ireland, I have a lot of collision athletes, so I do a lot more Latarjets now than I saw when I was a resident in Boston.
I think your comment about open instability repair is really interesting, because for me in my training, I've actually never done an open Bankart repair. I finished residency in 2010 and fellowship in 2011, and I never saw it during any of my training. So it speaks to that comfort level, other than
Mhm.
open Latarjet, but no, I didn't see any open arthroscopic open pancart repairs.
I think that's probably the same for most of us that trained around the same time or a little bit later. Um, Gilles, you have shown impressive results with the Latarjet procedure, and I think I know the answer to this one, but maybe just for the benefit of all of our listeners, I'm going to ask you, is or was there any place at all in your practice for soft tissue surgery and shoulder instability?
Purely soft tissue procedure for anterior instability. I cannot say never because it's stupid, but I tried to do a capsular shift according to Charles Neer for multidirectional hyperlaxity with a very loose shoulder, loose patient. I did not work, so I did some. It did not work. Cases of anterior instability with rotator cuff tear, also maybe controversial because sometimes you may repair the cuff, repair the subscap, and avoid the bone block procedure. I did for few anterior instability with subscap repair, but few of them, because it's pretty rare. Bob Neviser reported a series of 11 cases of anterior instability with an isolated tear of the subscap. I remember this paper, and he reported very good results with just repair of the subscap. So I did that few times. Otherwise, I tried in my career, of course, I tried arthroscopic Bankart repair. That was in 1987 after Morgan reported his technique in journal Arthroscopy. I did about 100 cases. I followed my patient and I reported the results. I had 50% recurrence rate in case of recurrent anterior instability, not painful shoulder, but recurrent anterior instability, so 50% recurrence rate. At that time, it's true that we just repair the labrum at the anteroinferior part of the glenoid. We did not do remplissage, of course. We did not put anchor inferiorly or posteriorly. I did some rotator interval closure at the same time. I did slap repair already at that time, but I did not perform remplissage and posterior-inferior capsular repair. So yes, I did some cases without bone block, just purely soft tissue procedure. And honestly, I was not very happy with my results. I had less satisfactory results than with the Latarjet.
And Patrick, how do you make the decision in your practice between a soft tissue surgery and a Latarjet or any bony reconstruction? What things make those decisions for you?
Yeah, it's a combination for me of bone loss in the patient. If the patient, if they have bone loss, then especially if the patient has had multiple dislocations where I can see obvious findings on x-ray, then I will make sure I get a CT over an MRI. And if they have over 15% glenoid bone loss, then I will make a case-by-case decision. And for instance, if the patient's less than 25 years of age, if they're a high-risk athlete because they're doing a lot of contact, I'll actually go to a Latarjet in that case. But conversely, if I run into a 35-year-old who is, doing some biking and maybe some tennis, and they just have not had appropriate treatment, even if they have larger amounts of glenoid bone loss, I may consider remplissage because that patient's at lower risk. And we actually have a paper that's accepted in OJSM that looks at patients with substantial bone loss. We had reasonable results. So it's still like everything. There's not absolute numbers. It's a case by case, right?
Yeah, I agree.
Sorry,
I think
Patrick, sorry, Ruth. When you say remplissage, you mean arthroscopic Bankart plus remplissage, or just remplissage.
Bankart with remplissage. Yeah.
Okay.
Okay.
Yeah.
Yeah. That makes sense. I think, as you said, it's like everything. We spend a lot of time at meetings talking about on track and off track and trying to measure everything. But also there's the individual patient and the demands that they're going to put on their shoulder.
You're
Gilles, do
right.
you?
So
Yeah.
the problem with the on track, off track, it's a nice way to try to understand the problem and the amount of bone loss, but it doesn't take into account patient age, patient activity level, and soft tissue laxity. So I think,
For sure.
there's patients who they may be on track, but you actually need to do a remplissage, and that's another one that we just looked at a series of people with subcritical bone loss, and we define that as less than 15%. And we had lower dislocations when we added remplissage for those patients, and something like over 90% of them were on track. It wasn't statistically significant, but it was still 9% in the isolated Bankart group compared to a couple of percent in the remplissage group at 2-year follow-up. So I think you still have to use your decision making and understand the patient on these cases.
Yeah, that's really true. That's so interesting. You can't just blindly trust numbers.
Yeah.
Gilles, do you think it's possible for surgeons who only occasionally do a Latarjet procedure to achieve or replicate the results achieved by a surgeon like you who did a high volume of them with a lot of success? Do you think that there's an issue when somebody only occasionally does it?
There is an issue, yes, because it's technically demanding. I recognize that. You must be very precise. I think that it depends on your teaching. If somebody taught you how to do it correctly, everybody should be able to do it because it's not absolutely impossible to do it, but you need to learn it correctly. If you do not learn correctly, yes, there are some risks. The nerves are at risk. Also, you may have a fracture of the coracoid process. You may have overhanging bone block in the joint. So, yes, there are tips and tricks that you must know before doing that. And I would not encourage a young surgeon to do 3 Latarjet a year. But on the other hand, I would not encourage him to do a 3 Bankart repair with remplissage either. You need to practice to be good anyway. But yes, I recognize that the technique is demanding, and you need really to know each step. What are the risks, the traps for each step, and so that is what I think about the technique, really.
And are both of you using sort of a classic open technique with the coracoid in the classic position rather than any variations like congruent arc or anything? Maybe Patrick, what's your technique when you do a Latarjet?
I do a subscapular split with congruent with the classic technique. I do not do a congruent arc. No, I mean, first of all, I feel like I'm a decent shoulder surgeon, and I still have a hard time with Latarjet. Honestly, I mean, I do almost 300 shoulder replacements. So I'm really comfortable with exposure, but I still struggle with Latarjet. Yeah, out of all my procedures, that's the one that I still watch Gilles' video before I go and do it again, and maybe it's the volume issue. But that's my experience. But just getting back to your question, I do the classic technique that Gilles described. The congruent arc, I think, is nice for the idea of having the biomechanics and the contour, but I really like the idea of having more surface area with the undersurface technique. And I think the subscapular split makes a lot of sense based on the literature. It is a lot more challenging. I think if somebody's not going to do a lot of Latarjets and they are going to do one, I think it's actually reasonable to do Burkhart's technique and take down the top half. Because that exposure part, to me, is the most challenging in getting the graft placement right.
Yeah, I think it certainly is an operation that deserves respect. And I like you, Patrick, I still stress a little bit about Latarjets. I do most weeks, one or two. Some weeks I have three of them.
Oh, wow.
But because of our population, but they're all big collision athletes, rugby players, but that means they have big deltoid, big pec, really thick subscap. It's a big muscle, and I still have a lot of respect for the operation. It's not just, for me, it's not just something easy routine, but I think, we've all learned from Gilles and we all watched that video.
Also, there is maybe one point important. I always did my bone block procedure, my Latarjet procedure, early in the morning. I always started the OR at 7 o'clock with one Latarjet, or two Latarjet, or three Latarjet. I never did the Latarjet in the afternoon because the patient is not relaxed. And especially if you have to operate on big athletes, it's crucial to do them in the morning and to have the anesthesiologist in the room, because you can really have a hard time if the patient is not relaxed, completely relaxed doing the Latarjet. And when I'm able to do it with 3 or 4 or 5 centimeter incision, it's just because of that. In the morning at 7 o'clock, the anesthesiologist know exactly how long it takes for me, and the patient is totally relaxed. And I've seen many times surgeon or friends having a hard time just because the patient doesn't sleep or is not relaxed. So we really need to have a patient fully relaxed, especially the athletes, if you do not want to have hard time.
That's a really good tip. I noticed when I visited you that you always started with them, but I didn't really know the reason. Often I start with them because I like to, get it out of the way while I'm fresh. But I guess that's another really important reason that all of the muscles that we're dealing with are pretty big. And the subscap, we as arthroscopists will look at the subscap tendon, right? And we don't see a lot of it, and we forget that this is a very big muscle on the front of the scapula. So I think that's a really important tip about the muscle relaxation for everybody to think about.
Yeah.
And then, Patrick, for any of the maybe earlier career listeners who might not be so familiar, can you briefly go over what is involved in the remplissage technique and maybe outline for us how you do it?
Yeah, sure. So tips wise, to me, one of the biggest things is making the decision early to do it. I really think that, first of all, I do all my scopes lateral, and I think that if you're going to do really good instability repair, I think there's some evidence that says that a lateral position is ideal. So I will typically scope, just start from the back, get a quick view, but I will very quickly go to an ASL portal to get the profile view of the glenoid and see to the back and assess the Hill-Sachs lesion. And if I decide I'm going to do the Hill-Sachs, do a remplissage, I will go ahead and put my anchors in right away. And then I will do my Bankart repair. Then I'll come back and close the posterior capsule with my remplissage. I hear sometimes people say, well, I do the remplissage if I can still see the Hill-Sachs lesion after my Bankart repair. And I don't think that's a good way to make the decision because you get swelling in the back area and it gets harder and harder to see as you go on. So anchor placement first, do the Bankart repair, then come back and close. As tips for that procedure, aside from getting to it early and viewing ASL, I think it's important to come right in line with the defect and the posterior capsule. To me, it's really a posterior capsulodesis. And in fact, when you look at where the anchors are going through, you're actually going through a bit of the muscle in some cases. So I think you're bringing down that capsule and you're trapping a little bit of muscle when you do it, actually. It's not really a tenodesis. I mean, if you think about the anatomy, the tendons don't extend over the cartilage of the head where you have that defect, right? So, I think it's just important that you come in line so you're not over tensioning or under tensioning. And I just try to go right up to the edge of the cartilage defect for the most part, unless it's quite large, and then I may be a little less aggressive to just kind of split the difference, so to speak.
Mm-hmm. It sounds like from in some of your recent publications, you have not really seen the problem of external rotation stiffness, which is one of the common things people criticize about the remplissage as a procedure. Is that something that you see, or do you think that's got to do with your choice of anchor placement?
Yeah, I think it's probably a choice of anchor placement. You know, overall, the literature doesn't really well bear that out, the external rotation loss. It certainly was a concern early on. In the paper we did with Johannes Barth out of France and Alex Laterman and Pablo Narbona, we did actually have lower external rotation in the remplissage group compared to the Latarjet group. But most of those Latarjets were done by Johannes, so there could be some variability in just how they were measured because we didn't have one reviewer. And interesting, when we compared our Bankarts to our Bankart remplissages, we had no difference in external rotation. So we had similar surgeons. So I haven't seen it, you know, and one of our studies said maybe there's a little less, but the other one did not.
It's really interesting. And then how about both of these procedures that we're talking about? Do either of you ever consider needing to add a remplissage to a Latarjet? Is that something, Gilles, you've ever thought about? You know, if a Hill-Sachs looks really big, is there a limit to what a coracoid graft can handle, or do you think that the overall mechanism of the Latarjet is always enough?
Well, I've done once in my life when I was visiting Professor Hardy in Paris. That was probably 15 years ago. And he presented with a patient with a regular anterior instability, and he asked me to do the Latarjet procedure for his department to show how I do the technique. And he said, "But look, there is a Hill-Sachs lesion, and could you do a remplissage at the same time, or it is not possible to do it with a Latarjet?" I said, technically it's possible. There is no problem to do that. It's not necessary. He said, "Oh, do you think it's possible to do the remplissage with the anterior and with the deltopectoral approach?" I said, "Yes, it is not technically demanding." So we did it. It's I just put the arm in full internal rotation to get the infraspinatus in front of the joint. And I did the remplissage at that time. I don't know how was the patient after, but he had also regular Latarjet, so I'm not afraid. So anyway, it's possible to do it. I did it once just to show that it's possible to do that at the, via a deltopectoral approach. But for the other patient, the cases I know which are a problem with Latarjet, with big Hill-Sachs, are epileptic patients with seizures. For a patient with seizure, recurrent anterior dislocation, huge Hill-Sachs lesion, it could be a good idea to add the remplissage. I'm not sure that it will prevent the recurrence because the recurrence are more related to the crisis, the seizures, than to the Hill-Sachs lesion, but it could be a good indication. Otherwise, if we eliminate the patient with seizure, even with a regular Hill-Sachs lesion, I honestly do not need to do a remplissage because I did not observe failure of the Latarjet procedure. So I would simply say that yes, if there is a big Hill-Sachs, you can do, especially if you do an arthroscopic Latarjet, you can do a remplissage, but with open procedure, it has not been necessary in my experience. So it's the reason why I do not do it. Also, I think it's a good operation. I have no problem against it.
Mm-hmm. How about if the patient has, if the patient has a very small coracoid? I mean, we put so much time into pre-op planning our arthroplasty cases, and maybe it's not relevant or necessary for the instability or the Latarjet cases, but, you know, do you think it matters the patient's individual anatomy of their coracoid if you have a small coracoid, or does that make no difference because you also have the sling and maybe the capsule?
I think that it makes no difference. If you have a very small coracoid, it's usually because it's a very small lady or so, a very small patient. And so you can put only one screw, of course, but the constraints on the screw will be much less. The patient has less muscles. So for me, the size of the coracoid is not a concern.
How about you, Pat? Do you have situations where you combine like a bony procedure and a remplissage, like a Latarjet in the front and a remplissage in the back, or do you trust the Latarjet on its own for everything?
Yeah, I've done it. So I don't have a large series, but I've done remplissage after a open Latarjet, where somebody had persistent sense of instability. They were mainly positive apprehension, but they did not have true dislocation. That was effective in that patient. I've also done the combined bone loss where there's massive bone loss with a seizure patient, and I have somebody scheduled to do an arthroscopic bone block with remplissage, and exactly what Gilles said is seizure pain with just huge bone loss. We just did a biomechanical study looking at that. We looked at free bone block versus remplissage, and we actually looked at free bone block versus Latarjet, and we looked at the addition of remplissage in the free bone block patients biomechanically, and we did find that it improves stability in a large off-track bipolar bone loss model. I think there's definitely some potential there as we continue to move toward arthroscopic, because it's just going to be easier to facilitate that procedure, especially arthroscopic bone blocks versus free bone blocks versus arthroscopic Latarjet, because I think that procedure is going to be easier to do for people, and then I think they will probably recognize Hill-Sachs lesions, and we'll see an increase in that combination procedure.
So you think that an arthroscopic free bone block is going to be easier than an arthroscopic Latarjet, or easier than an open Latarjet, or both? Easier than
I mean, I don't have enough experience. I've been working on this in the lab. I have been I was slow to really pursue arthroscopic Latarjet just because of my volume of Latarjet not being enough. I didn't feel to adopt that. But the free bone block techniques, I think, have gotten a lot easier. And I have found, at least in the lab, that I feel like it's a very straightforward procedure for me to do. In fact, I think it's going to end up being easier for me to do than Latarjet, yes. But I can't tell you for sure yet, but I do believe that right now.
I guess maybe the interesting comparison in the future will be an arthroscopic free bone block plus remplissage held against the classic open Latarjet as our gold standard, with everything. Gilles, this leads us on to the next topic really nicely. I was thinking about arthroscopic Latarjet and all the evolution that has gone on. What do you think about the evolution of that technique, the different fixation options? I mean, do we need it? Is there any advantage to going down this road, do you think? Or, can that ever be as good as the classic, I guess, what I and a lot of us call the Walch procedure, the modern Latarjet? Where do you think we stand with all of these arthroscopic variations now?
Well, I think that the results reported by Laurent Lafosse are wonderful, really incredible, and I can testimony about that because I visited several times Laurent Lafosse. We did a symposium together comparing the results of arthroscopic Latarjet with open Latarjet, and clearly the results of the arthroscopic Latarjet are the same as the open Latarjet. But Laurent is a wonderful, incredibly skillful surgeon, and is able probably to do some things that other surgeons are not able to do, and I am not able to do what Laurent does. So I would say that arthroscopic Latarjet could be the future for the surgeon, the young surgeon, who takes time to learn how to do this technique and to accept to spend 2 or 3 hours the first times to do that. And if they have a good teacher for arthroscopic Latarjet, it is as good as open Latarjet in my mind. And I always recommend to the young surgeon to go visit Laurent and to learn how to do it.
So at the moment, Patrick, do you use arthroscopic bone block procedures much in your practice, say versus open? I know you said maybe it's not high volume, but are you still more of an open Latarjet surgeon?
No, I've been open Latarjet. I mean, I'm just transitioning. I've been playing with it in the lab last year, and I think I've done my last Latarjet, but well, at least in terms of what I have scheduled going forward is bone block procedures.
Right. So I guess we'll have to ask you again in a few months.
Yeah.
See how you stand then.
Patrick, may I ask you something?
Yes.
Do you stop with arthroscopic Latarjet because of complication or because of lack of time in the OR? So for what reason do you say that you prefer to move to another surgery?
So I never did arthroscopic Latarjet. Um, I didn't see the huge advantage to doing the Latarjet arthroscopically because I felt like I was still having to do a split in the subscapularis. I was dealing with additional variables that could increase my complication rate. I wasn't doing enough of it. So I thought, in that case, I'm doing an open Latarjet. As the techniques have evolved for an open bone block, I see advantages there. One is the ability to add remplissage like we're talking about in some cases, but the primary advantage to me is if I can restore the glenoid without violating the subscapularis, because these patients to me have a high risk for arthritis down the line and going on to a shoulder replacement, etc. And to me, the Latarjet changes the type of shoulder replacement I do down the line. So I'm hoping by restoring their anatomy, I can preserve their subscapularis. And if they get post-traumatic arthritis, I can do a anatomic arthroplasty. That's my hope. So it's really, I just feel that there's some advantages to the free bone block over the Latarjet.
Did you observe oftentimes problems with the subscap after upon Latarjet? You say that the subscap is
Yeah,
crucial.
I haven't been in practice, I don't think, long enough to see that. I don't see it immediately afterwards. What I see are the patients who have had a Bristow procedure 20 or 30 years ago, somewhere else, and I've seen a fair amount of those with subscapularis atrophy or with even subscapularis tears. It's always hard to know what the surgeon did at the time, so many years ago.
Mm-hmm.
But in those patients, when they've come to me with post-traumatic arthritis, well, a few of them have come to me with subscapularis tears that have actually gone and repaired arthroscopically, upper portion tears, or they'll come to me with post-traumatic arthritis, and in that case, because there's the subscap's abnormal, I do reverse.
So Ruth, I think it's important for me to outline, to point out that for me, the Latarjet procedure is a very good procedure. I do not hesitate to do it, but clearly you must respect the subscap. And that means that if you want to do a correct Latarjet, you must be able to do it through a split in the subscap and never cut the subscap. I completely agree with Patrick that the main problem in the mid-term or long-term or even short-term follow-up after surgery for instability if you violate the subscap. So I defend the open Latarjet, but always preservation of the subscap, just split, and no tenotomy of the subscap at all.
That's interesting because I know we mentioned earlier that maybe for somebody who doesn't do them very often, it's easier to take down the upper subscap, like that Burkhardt technique. And so that's tempting for somebody who's not comfortable. But then you're, giving yourself a higher risk of these problems later on. And I think a lot of us, deal with these patients who have high numbers of dislocations before they come and have their surgery. They're at risk of arthritis later, even if you do a perfect Latarjet. And so I think it's as you said, a really important point that Even if it's tempting to violate the subscap, I think if you're going to do an open Latarjet, you have to learn to do it through the split.
Yeah.
And I mean, one criticism of the Latarjet, I suppose, is that it's non-anatomic, and so when there's a complication, when something goes wrong, things can get very difficult. And revision options in terms of revising in an instability situation can be difficult because you go back in there and it's hard to define the anatomy as well. What are your thoughts, Gilles, about revision instability surgery after the Latarjet and the difficulties, or do you find that it's still possible to do that without too much difficulty?
Oh yes, it's possible to do that without difficulties. I did it many times because I did many revision after Latarjet procedure from myself, but also coming from elsewhere. And so there is a tricks that is very important to know is you should not follow the conjoint tendon to find the previous bone block and the screw. Because if you do that, you are directly in contact with the brachial plexus. So the secret, when you have to do a revision of a Latarjet procedure, is go to the deltopectoral approach and then move laterally, meaning outside. Do not go direct in the front or medial, just go lateral to see where is the bicipital groove and the subscap insertion. And when you see the subscap insertion, just split the subscap about 2 or 3 centimeters, open everything, open the joint, put a retractor inside the joint, and work on the entire part of the glenoid from inside. And do not try to go outside to retrieve the screws. It's possible to do it from inside, and it's the best way to do it. So you split the subscap, you open the joint, you put a retractor inside the joint, you see the remnant of the bone block, if there is, you see the screws, you can take them out from inside the joint, and you can do a then Ibident procedure or free bone graft, like Patrick was speaking about, without any difficulties. Of course, this free bone graft has no sling effect, but it works. We reported the results with an Irish surgeon, as you know, John Loon. He did, when he visited me, he reported the results of the Eden Ibinet procedure for revision Latarjet, and we reported pretty good results. Failure we observed after that were always the same: seizure, epileptic patient, and voluntary recurrent anterior instability. Otherwise, the patient were happy. So that means also that a free bone graft is probably a very good procedure, as Patrick said. I have nothing against that. I just do the Latarjet because it's easy for me. It works. I have no reason to change. But I understand that a free bone graft, also according to Moroder in Europe, is good procedure. I think there is no doubt about that. With or without remplissage, no problem.
And Patrick, for you, have you had to go back in on many bone Latarjet procedures to revise them that have come into your hands, and have you had any particular thoughts about that situation?
Not too many, honestly. I mean, I think that Gilles covered that pretty well. The only additional thing that I think to really add there is I've taken a few screws scapically. If you have a superior screw that's prominent, I've done that. But I think he covered the revision aspect very, very well.
And then I guess when we're talking about these two procedures, remplissage and Latarjet, most of my patients are athletes. They're collision athletes. They're crazy to get back to their sport. They sometimes, they come in and they've heard from their teammates about how long it takes to get back to play from some of the different types of surgeries that we do. What are your typical return to play times for, say, a contact athlete, Patrick? If you do, say, a arthroscopic Bankart and remplissage, are you talking 6 months, or how do you decide when you let them go back to full activity?
I'm really conservative in general. I mean, with my cuff repairs, with my return to play in general. So I think what you're getting at is Latarjet versus Remplissage, and for me, it's 6 months in both cases. I know some people
Mhm.
let people go back to contact sports at 4 months or maybe even 3 months, but I just don't allow them to do that at that point in time. I'll let them go to the
Mhm.
gym at 3 months, but I don't want them participating in contact sports at that point in time.
Mhm. And do you check a CT after a bony procedure before you release them, or are you happy based on that amount of time having gone by?
I'm usually just looking at radiographs. I don't. I
Mhm.
only get a CT if I'm really concerned about something. But no, I like to um, look at the X-rays to see bony healing, and then I'll let them. I try to hold them out till 6 months. Maybe some
Mhm.
cases with Latarjet because I can see the healing a little bit earlier, but not routinely for me.
Okay. And Gilles, how about in Lyon when you take care of French collision athletes, rugby players, and you do a Latarjet? When do you let them start contact training again?
At 3 months, they are back to their sport at 3 months, even high level. And I would say that it's even easier with a very high level professional athlete because they ask that. They want to be back to the sports as soon as possible. And I have to recognize that I had some professional soccer player going back to the field, playing official tournament or official game at 2.5 months, for example. That happens.
Wow.
So I'm not.
Gosh.
Yeah. Oh yes. Even
I hope none of my patients are listening to this. I guess they don't tune in, but if any of my patients hear this, I'm going to be in trouble. I hope none of them hear that there's a possibility to go at 2.5 months.
oh yeah.
That takes
I,
some
I
courage.
would not I would not recommend that because we usually recommend 3 months, but our aim is really to put the patient in the good position to be back on the field really for official game at 3 months, and it's
Mhm.
usually what we try to do with Jean-Pierre Lyotard, the rehab doctor working with me, and it's usually possible. Again, some professional athletes, before the visit of the 3rd month, already played, and I saw that in the newspaper, that they played at 2.5 months, and I know it's possible. I would not recommend that, but if they feel comfortable, if they feel stable, why not?
It's
So you
probably
judge it.
it's probably population.
Sorry, Patrick, go ahead.
Yeah, it's population, I think, because what I hear Jill saying is he was taking care of a lot of contact athletes and professional athletes. That's just not my population. I take care of the high school athlete who dislocated in season, and I can typically shut them down for a longer period of time and bring them back. And if I had a lot of patients pushing me, maybe that would change over time. With like rotator cuff or arthroplasty, as I think about it, I've loosened up my rehab protocols as I've gone along because that's where my volume is, and I've been pushed by those patients
Mhm.
to do that.
It's
Mhm.
important also for professional
Yes,
because the president, the coach, they
yes,
push you,
Mhm.
and if you say no, you will be back at 6 months.
yeah,
Clearly, they go and see another surgeon.
yeah,
So
Mhm.
it's not a good argument, but it is an argument.
yeah,
Yeah. And I think the professionals set up athletes, they will do their rehabilitation so much more intensively. It's their job. They have, that's their full-time occupation to do this and to get
Yes.
back on the field. So I guess like we said about deciding about the surgery in the first place, it's somewhat of an individual decision. But no routine CTs for you, Gilles, before you let them back, or do you get CT scans on the post-op Latarjets? No.
No routine CTs, just plain X-rays. Uh, as you know, in France, we like to use a profile view of the glenoid, which is Bernageau view, which shows very nicely the bone block. But just plain X-rays are enough for me.
And then finally have one last question for each of you. We covered a little bit, but I think maybe to emphasize, Gilles, what are your top tips for a surgeon to get the Latarjet procedure right?
Well, first, to learn it correctly, to know by heart each step, by memory. I mean, do not think, what should I do now, what I have to do, and spend 2 minutes with your sponge to think about the future step. So you must know everything by memory and be able to do it quickly. That is my first thing, good teaching. The second thing is to have a good anesthesiologist with you. Because if you have to fight during all surgery against big deltoid, big pec major, a big subscap, you cannot do a good job. So you need to have a patient fully relaxed and the anesthesiologist fully aware that the surgery can be done only with a completely relaxed patient. Otherwise, it will take 2 hours, you will have complication and so on. So that is the second major thing. And the third point is to have the right instruments to do what you want. Because if you arrive at the time of the coracoid osteotomy and you do not have the angulated saw or you do not have angulated osteotome, it can be very, very difficult to do it. So I think that the retractor, also the type of retractor you use, are crucial. If you have just retractor for huge surgery, it's not possible because you don't want to open the arm from the top to the bottom. So all these tricks are, I think, important, and it's what I would put in the top of the tricks.
Thank you. And Patrick, for the remplissage, same question. You mentioned some of your tips earlier. What's your kind of top tip or top couple of tips to get it right? And also feel free to add any of your tips for the Latarjet as well, if you have some pearls.
No, I don't have any tips to add to the master on Latarjet. I think just to reiterate some things we said, know your patient, right? It's yes, the glenoid tract is a tool, but know really what the patient risk factors are. I think once you are making the decision, I think you should be talking yourself out of remplissage, not into remplissage during an arthroscopic Bankart repair. If you go in with the perspective that you're going to talk yourself into it, you are going to say, well, I don't really need to do that. And we're seeing that the results show reduced recurrence with the addition of remplissage with Bankart. So I think you should have that frame of mind. And then view from the ASL portal technically and place your anchors first before the Bankart.
Great. Thanks so much. Well, I'd just like to thank both of you for giving up your time to talk with us today and to share so much knowledge about these two instability surgeries. So many thanks to both of you.
Thank you. Thank you and congratulations. And I wish you all the best for the Dublin meeting in September.
Thanks so much. It's coming up soon. So hopefully we'll see some of our listeners there in person. And for all of our shoulder and elbow listeners out there, please don't forget to subscribe to the ASES podcast. I'm Ruth Delaney, and I want to thank the regular hosts, Rachel Frank and Peter Chalmers, for trusting me to host an episode for you. And we look forward to the next one.